Indeed, for inviting me to this talk. I'm very glad to share with you some information focusing a little bit more on pulmonary atresia and VSD and trying to sort of cover the modalities that haven't been mentioned before in this session. I don't have any disclosures, unfortunately. We're talking about tetralogy, and we all know there's highly variable pulmonary perfusion in these patients. There is multifocal perfusion in many of them. So diagnostically, as we've seen before in the previous beautiful talks, we need to take care of that. And those are the main tools that we are sort of using in clinical practice. So scintigraphy, MRI, CT, as we've heard, cardiac catheter, both conventionally. It still does happen conventionally as well, including 3D rotational CT, as we've heard from Sven. All these modalities need to image both the central pulmonary vessels, but also the peripheral perfusion in the lungs. Some of these methods are qualitative only, others are quantitative, and this may be useful in various different clinical scenarios. We've heard before, some of them are invasive, others are non-invasive, some of them use X-ray, others don't. Most importantly, the availability of these techniques plays a practical role in the clinical setting. It doesn't help to have a beautiful technique where you have to send the patient to somebody else. And also, you always need to ask yourself, is that really established what we're doing? Are we looking more or less at a research protocol? So starting with old-fashioned scintigraphy. So basically, that's giving us beautiful information about peripheral perfusion. It's quantitative, it is very established, it certainly uses X-ray, it is non-invasive, and it's quite readily available in most centers. So it's just to give you an example, without going into too much detail on this old-fashioned technique, but still, you use technetium-99 macro-aggregated albuminum. Doses are as given here, and this is just a normal projection from anterior aspect, right anterior oblique, left anterior oblique, and from the posterior aspect down here. You can see that's a fairly normal scan. Good thing about that is you can sort of quantify the counts that you find in the upper and the middle and the lower segment of both lungs, and that's information that's quite often quite useful in addition to the transcatheter or CT or MRI or whatever delineation of the collateral arteries in these patients. That's just an example to show you that if there is runoff of nuclear activity within the infusion into the venous system and the pre-pulmonary heart side, then you get staining of the kidneys. And you can use that information to actually calculate the right to left shunt, as we've done here in a 10-year-old with a VSD and the beginning of Eisenmeyer's reaction. This is an example of a post-repair tetralogy patient with LPA stenosis, and you're now expert enough to see that this is clearly underperfused here, seen from the front and seen from the behind. And after treatment with the stent, this is what we've been using over many, many years to show there's actually improvement of the left lung perfusion, seen from the front here on the right side and from the back here on the left side of the screen. Now, bilateral perfusion defects, that's very important, particularly in the patients with pulmonary atresia and multifocal pulmonary blood supply. As you can see here from the front, the right lung receives ample perfusion with some defects here, but the left lung is severely diseased in this patient. And this is another patient where actually the perfusion of one of the lungs is completely absent here, as in this patient as well, where you have a sort of almost totally occluded left pulmonary artery, as you can see on the lower part of the screen. So methodologically, you have to be careful about a few things. If you have a tetralogy patient with significant severe chronic pulmonary regurgitation, that, as you can see here, happens more often through the RPA than the LPA. And if you've got a lot of difference in pulmonary regurgitation between the two branches, then your scintigraphy scan might be inaccurate. As seen here in patients where there's a normal serial circulation after heart repair, with no significant regurgitation of valves and no mixing between the ventricles. You can see it's a beautiful agreement between scintigraphy and MRI, as shown by Surab Fratz from Munich a while ago. And this is patients from Surab again who have a fontan-type circulation. There you're lacking the subpulmonary ventricle, so the tracer doesn't get mixed, and that leads to preferential flow abnormality that just gives you the impression of an underperfused lung, which actually is well perfused. So take it all together, it works best in a biventricular circulation. Errors are possible due to the injection site. They are possible particularly in pulmonary regurgitation if you've got differential regurgitation from both pulmonary branches. And as we've seen in Fontans and Glenn, it's probably an inaccurate technique that should not be used. Moving on to magnetic resonance imaging. Well, that's a technique which is very versatile, so it's a bit difficult to decide over if it's central or peripheral. It certainly has qualitative aspects, but also quantitative if it comes to MR flow. It's fairly established, but there's a lot of research still going on, further improving the methodology. Fortunately, it's non-X-ray and mostly non-invasive if you don't combine it with catheter techniques. Unfortunately, it's not very good available in some centers, and that's still a drawback of that technique that we need to recognize in our clinical practice. It is versatile. We can get the pulmonary regurgitation, as you can see here. We get the function and the anatomy of the ventricles. We can cast 3D models of the pulmonary artery to plan our interventional or surgical procedure. But analyzing the lung perfusion, what the technique we mostly employ is actually 2D flow imaging, as you can see here. So that's flow alongside a gradient that gives you a phase shift from which you take the flow pictures. And that's the result you're getting. You can have a black and white staining if the flow is in one or the other direction through the screen. And that gives you a good accuracy in vitro if you use a flow pump, so that's quite encouraging. However, if you use it in the clinical scenario, use clinical scanners, you can see here that's a multi-vendor trial looking at the in vitro performance of scanners. And that's the green area, that's the error that is clinically acceptable. And you can see most of the scanners are wide apart. So you need to be careful if you look at flow measures. They sometimes are not as good as they promise to be. Well, in pulmonary atresia after repair, particularly the pulmonary regurgitation is important to know. So we will probably measure the flow in the main pulmonary artery trunk or the conduit that has been placed between the right ventricle and the pulmonary arteries. But then you can also get a very good measurement of the global right and left pulmonary perfusion through these very simple flow velocity measurements, as you can see here in the respective stroke curves of the pulmonary artery here and the branch pulmonary flows here. So that's very important information. It resembles a little bit this scintigraphy information that we had earlier on global differential lung perfusion that could guide a decision whether or not to put in a stent in a particular branch stenosis. Obviously, you can also get the flows and the cardiac output through the pulmonary vessels and the aorta. And you can assess the pulmonary regurgitation. But again, you need to be careful because some of the protocols that you use inspiratory breath holds. And these data will be different from scans where you use expiratory breath holds and patients where you use free breathing protocols. All different numbers, and you need to know your protocol and you need to repeat it the same way if you see the patient again in clinic. So that again, you've seen that slide before. Very important to know that you may have very different regurgitation through the branch pulmonary arteries in the case of chronic PR. So that's something you need to take into account also when looking into the differential perfusion if you use MRI and not scintigraphy. If you use flow for to assess the pulmonary perfusion, there's one more thing you could do. If it's very difficult, in some patients who have a multitude of collaterals, it'll be impossible to measure them all with 2D flow techniques. You'll spend the rest of the week doing that. However, if you focus on the pulmonary veins, it's very well possible to get a very accurate estimation of the perfusion of that respective lung lobe on the right side and on the left side if you image the pulmonary veins. And that's not too difficult to do. So more recently, people have started using not only 2D flow techniques, but three-dimensional flow techniques sampled over time. So that's what we call 4D flow, which is actually an inaccurate description. And you can see here is a normal heart, and here's a patient with abnormal pulmonary perfusion by means of a total cavopulmonary anastomosis. You can see how it's possible these days to use that quite difficult technique, but still it's able to give you a very good idea of how much blood from the IVC and from the SVC goes to the respective lung, and you can see that on this slide here. These scans need a little bit of technical expertise. So basically you plan a box in the thorax around the heart, then you use some kind of control of the heart motion and of the respiratory motion. It's probably useful to do. Others use different approaches. Doesn't really matter as long as you take it under account. You've got to encode your flow, not just in one direction as with 2D flow, but in three directions as with this methodology. And then that's what you get. You have to be careful with some technical aspects. You need to be thinking about flow offsets because you're measuring a big volume, and you need to be sure that your phase errors are being taken care of by the physicists. Otherwise, you get a lot of errors. But if you do that, and this data from Titus in Berlin, you get actually a beautiful accuracy between 4D flow and 2D flow most of the time. So that makes it a very versatile and very useful technique to just scan a big box and spend the rest of the day analyzing all these massive data that you generate. So how could that be useful for pulmonary artesia and VSD? It's not actually been done, but people have used that in fontans, where you also have the problem of aortopulmonary collateral flow. And actually, you can just put a box around the heart, measure all the flow, and then you can compute systemic venous backflow against pulmonary venous flow, against aortic flow, in whatever combination you like, branch pulmonary artery flows, and calculate the aortopulmonary collateral flow. And that means you can quantify it for the first time in a very reliable manner, as we've demonstrated in a study that we've done together with Titus in Berlin. Now, moving on to analyzing lung perfusion by use of high-resolution 3D MR angiography. Now, this will be very short because we've seen so beautiful CT pictures. But actually, MR can do similar things, but not as good as CT, certainly without radiation, and certainly good enough to be able to plan further procedures. And if you do a catheter anyway, some people say, well, I just do an MR angiogram, and that's all I need to plan my catheter or do my image overlay in the cath lab and avoid the radiation. But if that comes down and keeps coming down even more, then maybe a 3D GAD angiography for this indication will get away. But it's possible to, sorry, I've just clicked one more. It's possible to see, for example, connections between, well, it's not going to stay, this picture, so sorry about that. No, it's not going to stay. It's possible to see also communications between collateral vessels and the genuine central pulmonary artery system, but not as good as with CT. However, what is interesting is a new development which is called time-resolved 3D MR angiography. So that means that you get very, very many 3D samples scanned over time, and you can actually start. This is the trick how to do that. You just scan the center of K-space and sort of copy-paste the rest of the K-space into these different dynamics. This scheme shows you how that works. Basically speeds up the whole thing by the factor of almost 10. And then that's what you get. You get sort of a single injection of contrast dose. And we've made that long time ago, that movie. And you can see here in a post-repair tetralogy patient with RPA distal stenosis and upper lobe branch stenosis of the right pulmonary artery, conduit stenosis. You can actually, if you look into the periphery of the lung, you can get some idea that it should be possible to have some kind of intensity over time, three-dimensional analysis of the pulmonary perfusion and move on towards more peripheral information rather than just central imaging of the sources of pulmonary blood supply. Now, that's been done by Vogt et al. In a recent study. You can see here in a time-resolved 3D angiogram showing very nicely how the RPA in this patient with pulmonary arteria VSD and discontinuous central pulmonary arteries, the RPA is being perfused through the duct. So contrast agent moves into the ascending aorta, moves into the duct, as you can see here, stains the right pulmonary arteries. You don't see a trace of the left pulmonary artery. And you wait and you wait and you wait, and then suddenly it starts coming right to the end of the dynamic scan, suggesting that it's just collateral artery supply to the whole of the left lung. So that's nice information. I quite expect that this will move into clinical practice because a lot of research interest from the adult medicine is on that particular technique. That's just another patient with an Epstein's anomaly. Again, you can see here that the left subclavian artery would not trace, really. It does trace, but only after the whole thing has passed through the vertebral artery, suggesting blockage of the proximal left subclavian artery. Now, it's very tempting to use that methodology to get actually 3D information on signal intensity over time, as we can see here from a paper from Tomasian in 2009. And actually, that's the first step towards quantification of peripheral pulmonary artery perfusion. You can see here a post-repair follow patient with an LPA stenosis here on the screen. Those are the patients where this starts making a lot of sense. And here you can see the right lung is stained first. Left lung is not really stained at all. Left lung is stained very, very late in the course, suggesting severe stenosis of that vessel. And you should be able to quantify that. And that's a patient with, after unifocalization with collaterals. And you can see here in a comparison of MRI 3D over time resolved compared with scintigraphy, that there's very nice correlation between the two methods in terms of peripheral pulmonary artery perfusion. Right, moving on to catheter. It is certainly very invasive. It's available. You can do it yourself, which is something that people really enjoy. It gives you central pulmonary artery information, but also images very nicely the periphery. It is qualitative most of the time. It is a very established technique and obviously uses X-ray. Just some examples, you've seen that before, injection into the right ventricle on the left side and left ventricle on the right side in a patient with pulmonary arterial VSD and MAPGAS, 80 months of age. It came late to us. This is another angiogram showing collaterals from the descending aorta that nicely communicate with the central pulmonary artery that you can see here. And as you move on, you can also see collaterals from the abdomen with a single supply of the right lower lobe segment, posterior segments. And then you can sit down, analyze all that, and make your drawings and sit together with the surgeon. That's sort of the conventional way that people have used over many, many years to plan the clinical care for these patients. And that should be covered as well in a session covering imaging in pulmonary arterial VSD and MAPGAS. Now, this is what we've heard from Sven. It's a beautiful technique. It is, one thing is the roadmap imaging that Sven has so nicely explained. However, another thing is that you could have seen on Sven's images as well, sometimes you see a red mark here and a blue mark here. The blue mark means basically you would be able to get the same projection in the normal cath lab. If it is red, it would be impossible to get that projection in the cath lab. And actually, if you compare the stenosis here to the stenosis there, you will find that this one needs different projections to be able to really see what's wrong with the patient. Sometimes in a particular projection, you over or you underestimate a particular obstruction, and that's very important information as well. And the same thing here, a collateral from the descending aorta that you can't really see on that. But if you turn the data set, you look from cranial down, you can see that it moves out of the aorta quite posteriorly and turns around here, and that's important information for surgical planning. Well, takeaways. Scintigraphy is simple. It's non-invasive. It can give you quantitative information on the peripheral perfusion. It's long been established. Little data in congenital heart disease, little research going on. But it's a very, if you know the limitations, it's a very useful test. And radiation isn't too bad if you use it. We've discussed the details before. On MRI, obviously non-invasive and non-X-ray, you've got a very thorough assessment of the whole cardiovascular system. You get ventricular function, valvular function, also very decent information on the anatomy of aortopulmonary collaterals, for example, and central pulmonary arteries. However, the 3D information isn't as good as the CT, and you need to make a good decision whether you want to use it or not. MR flow on 2D can give you quite decent information on the on left and right lung perfusion, and some information over low perfusion if you scan the pulmonary veins, as we've seen. 3D angiography, certainly if it's time resolved, is going to be a very important addition to the diagnostic tool in these patients, as it may give you very nice peripheral perfusion information in 3D. CT, you've already heard beautiful talks on that, so I'm not going to further go into that. It's not ideal if you look into peripheral perfusion information, obviously, and connections between collaterals and central pulmonary arteries can be imaged, but not always very easy to see. Certainly not as good as a catheter injection into a collateral that feeds back the central pulmonary artery, but very useful, particularly if it's about airways as well. Catheter obviously continues to be the reference method. It uses enormous X-ray. People talk a lot about CT radiation, but little about catheter radiation, but it's really substantial. I think that's the big thing, to use those overlay techniques to really be able to bring down the catheter X-ray exponential in these patients. Now, I think we've covered the whole thing pretty much, and I'd like to thank you very much indeed for your kind attention.